Hello everybody. These are some cases that we've looked at prior to Module 5, Week 1 in the Advanced course, Semester 1. I think we had dealt with this one of Nene's last time. I'll just go back and have a quick look at it. Ah yes, we did. Non-itchy, non-painful rashes in her hands and neck since she was a 24-year-old. She's 37. And was reported as an interstitial granulomatous dermatitis, a variant of GA. We had difficulty with this, if I remember rightly. If we just look at the distribution of this rash and the nature of it, it looks red and it looks scaly, or at least it's partially crusted. Here, there's peeling of the skin on the surface here. And whenever you see something like that, you're really expecting that there's going to be an epidermal component of some type to give you that sort of peeling. So you'd want, I would really wonder about a fungal infection or some form of irritant dermatitis with peeling on the surface of the skin, or even discoid lupus with something in the dorsum of the skin like that. And this is a better close-up of this lesion. Annular erythemas could give you a scale somewhat like this as well, but it's used a much finer scale towards the periphery. But the recurrent nature of this with this particular patient, that it comes and goes, might have made me think of an annular erythema. But when the pathology was done, they say it was an unremarkable epidermis. And within the dermis, there were histiocytes, lymphocytes, eosinophils in amongst the collagen bundles, and some multinucleate giant cells as well, but no granulomas. And there was no fungi seen in the PAS stain. So they diagnosed that as interstitial granuloma annulare, and saying there were no features of lupus. And I think chilblain lupus, discoid lupus was a very reasonable clinical thought of Nene's when she sent the biopsy in with this. I can't see I've seen an interstitial granulomatous dermatitis present like that. It's usually a drug reaction for most people anyway, and generally it's a smooth infiltrated plaque that they get usually on the abdominal wall, rather than anything like that. In fact, let me just see if we can sort of bring up any images for interstitial granulomatous dermatitis. Let me just check here. Let's go for Google and we'll see if we can get any images for that. Right, you can see the sort of pictures that they're giving here for that condition. I mean, that's more. This is more the generalized granuloma annulare rather than interstitial granulomatous dermatitis, when you see all these papules and the like. But again, large patches like this. Palisaded granulomatous dermatitis for this particular rash here. So you see the the variation in pictures, but the overall presentation is of a large patch of plaque, usually on the trunk. We'll lock that one out. So, not sure about that one. It just seemed to resolve on its own, which is a bit unusual. as well. I forgot to ask last time, Nene, does she require treatment for this to resolve, or will it just resolve on its own? Nene?
The lesions will resolve with the topic as go away by themselves.
Right, okay. Now, looks curious picture. I can't say I've seen anything like this. Lovely images. Difficult to argue with the histology, they're just not seeing anything else there. But you can
And,
see how most of those images that I showed you, they didn't show any superficial dermal component. Superficial epidermal component. It's all a dermal process. Okay, thanks
and,
anyway.
and Ian,
Yeah,
can I ask you a question? The pathologist did the PAS thing without my request. So do they usually do the PAS thing when we describe that the lesion is red and scaly, or
yeah.
they will do the PAS thing on every time?
Not usually. If you were to describe it being red and scaly, and if they felt that perhaps fungus was part of a differential, then they would routinely do it.
Okay,
It's not
got
a it's not a stain that they would automatically do, but on the history, it might well make them. If you were talking of discoid lupus, then a good pathologist might well do a PAS just to make sure they weren't missing anything like that. Or they may ask it afterwards if there's a big disparity between what you're describing and what they are seeing. Then sometimes they'll hold the specimen for 24 hours and run a PAS stain on it just to make sure that they're not missing a fungus. Okay, let's look at your next case here. 24-year-old female from Fiji, recurrent bilateral nipple eczema for the last 2.5 years. 2 or 3 relapses a year. She gets itch, pain from the cracks, no allergens. Nulliparous, never had breastfeeding, but she can get a few months remission after 1 to 2 weeks of topical steroid. Her relevant past medical history is atopic eczema. Sure. Grew out of it early, no regular medications. Photos are 1 week after she's applied Advantan, and no pain or itch. Nipples are usually involved. Right nipple is mainly affected. Regularly cleaned her nipples with soap. She's right-handed, so admits she scratches her nipples a lot due to itch. Hypopigmented patches. No active eczema. Rest of the breast normal. Let's have a little look. You can see the damage that's been done there with all those areas of hypopigmentation. This skin on the right side is, it's lichen simplex chronicus. It's really been rubbed and scratched, and it's really thickened here as well. Let's see if we can just. You can see how thick that skin is there. You can see some excoriations there too. A little bit of pigmentation around the outside. Yeah, that's a better example. That's better. Yeah, you can see the thickening of this. This is just lichen simplex, but it's certainly been scratched and excoriated. I mean, this is going to go hypopigmented like the other one as well. That's really massive lichen simplex. A localized type of dermatitis. And that's the left nipple. If she's right-handed, it's perhaps easier to rub and scratch the right side than the left. You just want a good strong topical steroid to break the itch scratch cycle, but it's interesting that she can go a couple of months without much in the way of symptoms at all, and then it starts to get itchy again. It's very difficult to explain why. You gave her general advice: stop daily cleaning with soap. Yep. Apply moisturizer regularly. Yep. That's probably good ideas. Dermies, some of the thick moisturizer applied to the skin. Wear cotton bras. Yep. No nylon or anything that's going to make us sweat. Try and control the attend GP for early if signs of infection develop. Yeah, I'd probably give her a tube of Bactroban to have handy at home as well. The Advantan's quite a good choice there. You might even need a stronger topical steroid at first to get that. And she did have a slight oozing the first time. It didn't grow any pathogens. No, I agree. I don't think there's any real concern about underlying malignancy here. I think with a past history of atopic eczema, you'll just get some um, females with a history of atopy who have a tendency to get nipple eczema. It's in a localized area that tends to get rubbed and scratched, and as you say, it's much maximal on the right side. I've never seen one quite as thick or as marked as this. Nene, let me unmute you. Sorry. There we go. Interesting case. Certainly quite marked lichen simplex on that right side.
Yeah, and I give her Elogon cream, and she said, no, no, please give me the same one I used before. And when I look at the old script, she was on Avanta.
Sure, sure. And she's happier with
Yeah,
that.
and yeah, why is unilateral? But could be from scratching by her right hand. However, her right hand can also easily reach
Reach
the
the
left
left.
breast. So I
Yeah, I understand that too. Yeah, look, I just think it happens. You know, it's the same with lichen simplex. It's often more marked on the handed side than the other side. Even if they can reach the other side, it's just easier, I suppose. Sometimes it becomes a habit with some people. I mean, that's how lichen simplex develops. It just becomes a habit, and the more they rub and scratch, the more the skin thickens, the more it itches, because of the unmyelinated C nerve fibers in the epidermis just firing off all the time. So you've got to break that itch scratch cycle. Make sure she cuts her nails. As you say, use the topical steroid to get it settled down. Then a good thick moisturizer, Dermis, something like that, on it regularly. And the cotton bras, everything else you said there was quite correct. But you'll just get some individuals who, like scratching the back of the neck, like scratching the cleft above the buttocks. Just get into a habit and have a localized area of dermatitis that can be quite difficult to heal because they're chronic rubbing and scratching. It's just their way. Sometimes with stress they'll do it. But I haven't seen a nipple one quite as marked as that. So good case, nice photographs.
thanks. Is
Any
it
Sorry, Nene, I'll just unmute you again. Yeah.
sorry, Ian. My question is it common to see hypopigmentation in this areolar area after inflammation?
Well, I can't say that I've had a lot of experience of it, but certainly, with sufficient scratching and injury, you can get post-inflammatory hypopigmentation, just as you can get a little bit of hyper around the outside. You certainly can get hypo. I mean, conditions such as lupus and the like are much more likely to cause hypopigmentation, but I'm not seeing that as any type of lupus. I'm quite certain it is, just as you say, a form of lichen simplex. But yeah, I think you can certainly get that with chronic rubbing. I mean, it's the same with the prurigo nodule patients. You know how you see their backs and you
Yes.
see where the white scars are, where they've been rubbing and scratching and breaking the skin surface in the past. It's the same phenomenon that you're getting there as well.
Thank you.
No worries. Any comments from anyone else on Braj? Let me come to you. Sorry, Braj, I've unmuted you. You just have to unmute yourself, I think. Yeah, Braj.
Can you hear me?
Yep, hear you fine.
Yeah, so just one, because I just joined, sorry about being late. But if there was eczema of the nipple, probably Paget's disease of the nipple should be also be considered. I'm like, of course, the age is there, but then that is the way it starts normally. So I'm like, I haven't seen the full pictures, but just
Sure.
because
No,
I saw that eczema.
I think the history and the bilateral nature of this and the recurrent nature of it and what have you, no, I really don't think you need to consider Paget's in this particular case. And it can clear up completely with this particular patient for some months and then flare up again. So, no, I honestly don't think you need to consider it. When it's bilateral like that, it's I've never seen a bilateral Paget's. I'm sure it's been reported, but I've never seen a bilateral Paget's, and I wouldn't really consider it. I wouldn't feel that you need to do biopsies of that in this particular patient, quite honestly. No worries. Any comments from anyone else? Siva. Yes, Siva. Sorry, Siva, I've unmuted you. Did you have a question? Your microphone mustn't be working, Siva. I'm not sure if you can take it out, put it back in again or something. Okay, I'll mute you. Okay, let's have a look at the other case that was there. Then I've got a couple I just want to show you, and we'll go on to the, what was this one? From Nazi. Let's have a little look. Last patient for today, new patient, 39-year-old female, rash for the last 9 months, usually starts with little itch, then rash comes up the next day. Does respond to strong steroid, comes in different places, arms, legs, abdomen. Non-scaly, then scales when applying the steroid. Okay. Let's just have a quick look at the rash. You can see, I think there is an element of scale there, almost cigarette paper thickening of the skin. If you've got any scale, remember you should always do a scraping just to exclude fungus. Let's load this one. Yeah, again you see that sort of cigarette paper type surface. But a little bit redder around here. You see that cigarette paper type surface, and a little bit redder around the top here. Yeah, it's the sort of picture you can see in chronic superficial dermatitis, you know, a very early type of parapsoriasis, T-cell lymphoma of the skin. But I'd always do scrapings here to exclude a fungal infection as well. And I think it does need a little biopsy. Let's see the other pictures. That's a better picture, gives you a better idea of the lesion. Those a couple of little pustules. And what else? Let's have a look at this one here. Yeah, it looks a bit of clearing in the middle, and you know, perhaps a little bit more inflamed. I'd certainly take scrapings of this. I think you want to certainly exclude a fungal infection on that sort of presentation. Yeah, if you've got scale, it's not granulomannulari. Rash, semi-round, more prominent edge. Yeah, you're going to do scrapings for fungus anyway, and a biopsy from the edge as well. If there's scale there, though, I really wouldn't expect granulomannulari, and that really does look as if there's a bit of epidermal involvement. So you know, do your scrapings. When you do your biopsy, ask for a PAS, and also just put down query chronic superficial dermatitis or parapsoriasis, and see what the pathologist says. Someone got their hand up? Frank. Yeah, Frank.
Oh, hi, yeah. If you do biopsy plus PAS, does that mean you don't need to do scraping because the PAS will show it's fungal?
Not always. You're always better. And even then, the PAS might show it's fungal, but it doesn't tell you what fungus it is. You might want to obviously find out. You see, the scraping is actually better than doing a biopsy and a PAS to determine a fungal infection. You'll get a bigger return from microscopy of skin scrapings for fungus than you will from doing a biopsy and a PAS. Okay, so doing the skin scraping, I do both. I do some skin scrapings and I do a biopsy for this, but I'd mention about query fungus in my differential, and they'll automatically do a PAS. But scrapings are generally still more sensitive to pick up a fungal infection than a biopsy and a PAS is. Okay?
Thanks.
No worries. No worries. Any questions from anyone else? Slip your hand down, Frank, if you're finished. Okay, so interesting case. But I'd be looking for a fungus there. I'll be interested to come back and just see what the histology and the like shows, and we can we can have a chat about that one later, Nazi, next time. I had a couple of cases I just wanted to show you, if I may. Don't tell me I've closed it down. I think I have. Sorry, bear with me 1 second just while I open it. So I'm having little problems with the audio connection tonight. It may be that the internet isn't quite as good as it should be. Just be a second till we get the... Why isn't AC/DC coming up? Let me try again. There we go. Sorry, bear with me 1 second here, just while I get these images up. I had them up earlier on, but the computer's having a little hard time here. Now, I may have a little bit of trouble getting this up. But I did have a couple of cases I wanted to show you that I showed the others. I'm not sure if I showed you this one last week or not, but this was a case that just came in a few days ago. I'll bring this one up from here. This was a person who he actually, I learned today, has Marfan syndrome, but he's also in with an endocarditis. You know, with Marfan syndrome, they have problem with heart valves anyway, and this guy's got an endocarditis as well, an unusual organism, and he's getting intravenous antibiotics for that. And when he was being treated for that, up comes this lesion on the dorsum of his wrist, of his hand. It's ulcerated in the center, but it's got, I'll just try and enlarge this. There's the edge to it, the slight undermining there, and I thought this was either sweets or early pyoderma gangrenosum. And I did a biopsy of this. I just took a punch from this area here, and it shows a marked neutrophilic infiltrate, highly likely to be Sweets syndrome. The guy had another small pink lesion on his other knee, that slightly purple lesion on his other knee, very small. I just did a punch biopsy on that to remove it, and it shows the very earliest features of Sweets as well. So he's getting Sweets syndrome as a reaction to presumably his infection and his endocarditis, because he doesn't have any of the other common causes of Sweets, the rheumatoid arthritis, the Crohn's, the ulcerative colitis, the chronic myeloid leukemias, or anything like that. But that was just a case of Sweets syndrome, and you get the feel for that. I mean, that was very obvious to me straight away that in fact was Sweets in that particular patient. Now, I'm not sure if I can show you the other cases. Apologies. I did have a couple of, this was just a little girl with granuloma annulare. I mean, that's typical granuloma annulare in the back of the foot. She's only aged 9, and she had that. Let me try and and get the other cases I wanted to show you. There's just a couple of them. Okay, I'll just show you them here. This was a man who's had a lot of solar damage and the like before. He had this sort of indurated mass here in his scalp with ulceration. I mean, to me, it could have been anything. Could have been a sarcoma, could have been a squamous cell, basal cell, might even been a Merkel cell carcinoma. I biopsied it, came back as a poorly differentiated squamous cell carcinoma, and I mean, this thing is all indurated. It feels there. I don't think you can tell really dermatoscopically with anything like this. You just have to do a punch, a punch or an incisional biopsy to it. If you can think you get the depth of it in the punch, just do a punch. But it was poorly differentiated SCC. You had to have special stains done to determine that it was a squamous cell carcinoma. He'll be getting sent away for a big skin graft he's undoubtedly going to have. So the point here is just you need to biopsy these to make a diagnosis. Could have been a metastasis as well. This was a lady who had an infection on her ankle from an insect bite reaction, was given flucloxacillin, and she had the antibiotics for about 5 days, and then 3 days after she finished them, bang, this rash came up. And you can see how florid this is. It did blanch, red, non-scaly, and just swiftly I'll go through the other pictures just to give you a flavour of it. You can see how marked the erythema was that she had. Normal skin in here, that's how red the skin actually was. And just a few of the other pictures. Just the side of her face. The other thing that was curious were these pustules that she had as well. And I did swab these, but I hadn't got the result back later today. I put her on a bit of Bactroban, and when she came in today, they had in fact all cleared, and this rash was a lot better. She had been on 50 of prednisone, and it was about the 5th day, and I told her actually to drop the prednisone just to 25 because I thought she was off the antibiotic. She was past the worst of it. Most illnesses like that get worse for the first 2 to 3 days and then start to improve after that as the drug's been withdrawn. There's no antibodies. Well, the amount of antibodies that are being produced are much less, less plasma cell activity, and so the rash will just gradually settle. So I dropped her from, she had been on 50 of prednisone, I dropped her to 25. I didn't give her anything topical. She was using an antihistamine for some itch that she had. She wasn't ill in herself, even though that rash looks quite dramatic and looks almost erythema multiforme-like in bits. She wasn't ill in herself. She didn't have any oral involvement. I had been worried it might, with those pustules, that it might be some form of AGEP, acute generalized exanthematous pustulosis. But there were no pustules elsewhere on any of those red areas. And I did do a couple of biopsies, and they just showed a features compatible with a good going drug reaction. So just an example of that particular condition. And the last one I want to show you is this case. This was a man, Aboriginal origin. I'd seen him in the past. He had this big cyst-like lesion here, scarred areas here. This felt quite boggy. I had treated him 2 years ago with Roaccutane he had 8 boxes, and it settled us down for almost 2 years. Then it started to flare again. This is dissecting cellulitis of the scalp. The condition that's sometimes seen along with cystic acne and hidradenitis suppurativa and pilonidal sinuses. This is the condition of dissecting cellulitis of the scalp. You can inject these areas here with a little bit of intralesional steroid. The diluted 1 ml of Kennicott A10 and 3 of local into here would flatten that down in a couple of days. But some cases are treated with prolonged antibiotics, others are best treated with the isotretinoin, and that's what I intend treating them with. Now, because of the success of adalimumab Humira in hidradenitis suppurativa, it has been suggested that a TNF-alpha inhibitor could be used to suppress the inflammation in this condition as well. But of course it's not listed for that here in Australia, so it's not an option that I can offer him. And I'm going to put him back on Roaccutane again in a dose, I think, of about 60 milligrams a day he was on. And we'll hopefully get that settled down again, and I'll probably end up giving him low dose Roaccutane that he's going to have to stay on in the longer term to try and keep this from progressing, because you can see how as it progresses there's hair loss, there's scarring alopecia that they in fact get. He's had ones opened up in the past. That's what some of these scars are. Before I saw him, they weren't quite sure what was going on, and they thought he had some infected abscesses and kept opening it up, but he'll settle once we put him back on isotretinoin. Any quick questions on that? So remember, dissecting cellulitis of the scalp. Not a common condition, but it's one that you certainly should recognise if it walks in through the door, just because of the nature. You might have wondered if it was Kerrion that he had, but he's not going to have it for that length of time. But this is dissecting cellulitis. It's all boggy. You know, you put your fingers on here. Sometimes with some of them when they're active, if you push in one bit, you see little beads of pus coming out of orifices in other bits there because of the sinuses and the like that are joining these areas up. Okay, I think that was all that I